Well, good morning, everybody, and welcome to the 2026 Kidney Disease Impact Conference. So excited to be here. I think this is my 10th year with Carolyn, and what an amazing event we have set up again for this year. So many incredible guest speakers and doctors that are going to be here today to speak, and also online. Real quick, I just want to go over the Kidney Quest Foundation and what they do for kidney patients around the world. The KQF is a nonprofit organization committed to aiding renal disease patients and their families in navigating the complexities of chronic kidney disease, dialysis, and kidney transplants. It was established in 2008. Our foundation has steadfastly served patients across various regions, including LA County, Antelope Valley, Lancaster, Palmdale, Orange County, Ventura County, Kern County, Santa Barbara County, San Diego County, and neighboring areas of Southern California. Moreover, the KQF extends its reach nationwide, providing case management services throughout the United States with additional outreach and support efforts in Atlanta and Georgia. Collaborating closely with medical professionals, KQF and its dedicated team of volunteers offer comprehensive assistance to patients, families, and healthcare providers alike. Beyond raising awareness, the array of all the services encompass education and information, including speakers programs, educational materials, monthly support meetings with kidney fitness exercises for patients, and a variety of consultation services on everything from health record management to renal diets to dialysis and kidney disease support services. The transplant list qualification and support to assist patients in all stages of the process to qualify for a kidney transplant and how to move up on the transplant wait list. Preparing renal patients on how to sign up for and stay active on these lists. How to be a live kidney donor, helping patients, families, and general public learn more about how they can become a live donor for kidney transplants and give the gift of life to kidney patients in need of a transplant. Community outreach, the community-based events to let people know we are here for them, speaker programs to provide qualified speakers for meetings and groups upon request, distributing educational materials. Dialysis center outreach, helping support dialysis units in LA County, Orange, San Diego County, throughout the entire United States, with telephone support for both Oakland and San Francisco. Meet and greet programs, which include activities based at dialysis centers, hospitals, schools, and healthcare events in the community. Emergency backpack distribution program, dispersing emergency backpack kits to kidney patients to help them survive in a natural disaster, such as earthquake, flood, or fire, or in case of an emergency. A KQF Stay Safe kit, face mask, hand sanitizer, disposable gloves are also included. Over its 18 years of operation, KQF has achieved substantial outcomes on behalf of kidney disease, their families, and the healthcare professionals. It's an honor to witness that Kidney Quest Foundation's visions was not in vain, and today there is progress, much progress, recognition and action being taken for individuals suffering from kidney disease. 2019 was a landmark year for increasing awareness of renal disease and the drive to promote kidney health as preventative when the Advancing American Kidney Health Initiative was launched by executive order from the President of the United States. At Kidney Quest Foundation, we continue to serve as an outreach center and are dedicated to serving the renal community. At this time, I'd like to bring up a dear friend of mine for many, many, many years. Our families actually go back to the 80s together. But I would guess to say that we wouldn't be having this conference if it wasn't for her today. So I'm just going to speak a couple words and then bring her on up. Carolyn Lemos, president. She started this outreach organization dedicated to families and individuals with kidney disorders and those in need of kidney transplants. The foundation to get people to focus on building inner strength and learning how to take action to manage their health and condition, and supporting kidney patients and families in the United States for over 18 years now. An extraordinary gal, a wonderful friend, and she has really given everything that she has to make this go and get bigger and stronger and better every single year. So I would like to bring up the president at this time. We'll give her a big round of applause, Carolyn Lemos.
Good morning, everyone. And I want to thank everybody for being here, to supporting, really bringing awareness in the community of where it's very much needed, and that's in pretty much everywhere today. Anybody that has been affected with any type of chronic condition that will lead up to kidney disease, and that's really been our mission. It's loving the people that have already been diagnosed, and loving the people is not just every day, it's just being there, sometimes just a voice for them, and advocating, educating, supporting them. And I can't do it without all the volunteers. This foundation is done, we function by volunteers. Everybody that helps us succeed every single day is the foundation. So there's no recognition on just Kidneys Quest. It's everybody that is part of Kidneys Quest. I want to thank the volunteers with all my heart. I want to thank our board of directors that have always been right behind us, and our fairly new one. But I also want to thank our future director, just all our collaborations that we have with everybody. I just want to thank everybody just being part today of our future collaborations. With that, I thank you, Barrie.
Carolyn, you are awesome. I'm a big fan. Okay, at this moment, if we could bring Mr. Charles Simpson up, we were going to do a prayer.
Good morning, everyone. Nice to be here this morning. I'm just going to open this up in prayer. If you could bow your heads. Thank you, Lord, for this day. Thank you. We are gathered here today with gratitude for one another. May this meeting be productive and guided by compassion, mutual respect, and the shared goals of serving the greater good. May our discussions be thoughtful, and may we leave inspired to make a positive impact. Hope something is said or done to encourage, to uplift, to motivate, to comfort, to heal, to inspire, to bring clarity. Bless all that are involved. Grant us these in your holy name. Amen.
Amen, Charles. Thank you. What a great way to get this thing rolling. Okay, at this point, I would like to bring up a quick guest speaker, and I'm going to just say a little something about Anna. I'm going to read her story. It's quite amazing. Her kidney disease was caused by diabetes, and after she began experiencing system of shortness of breath and walking and swelling in her legs, she started dialysis in 2018 and continued treatment until her transplant in June of 2025. During that time, she found Carolyn and the Kidney Quest Foundation, and they provided so much valuable knowledge and information. I'm very grateful for all the support from this organization and hope it continues to grow and others who need it so much. Today, post-transplant, I have a much better outlook on life and feel wonderful. That's so great to hear. I thank God and this foundation and everyone along the way who helped me go where I am now. So if we could welcome up Anna Rodriguez.
As Anna's making her way up here, I don't know if anybody knows anybody that's had a transplant, but it's a journey. It's a journey just getting diagnosed. Once you're diagnosed, you have a choice of the type of dialysis. Once you look at that machine, then you have to accept it as a future to your health and to your well-being. Then you get an opportunity for transplant, if possible. And when that happens, it can be a great day, but you're still a kidney patient for the rest of your life. You still are somebody that has to take that time for yourself and for your journey. So this is why we continue, whether you're on dialysis, you're diagnosed, or transplanted, you still have to continue to stick together like we are together to continue the knowledge and the uplift and everything behind it. So with that being said, this woman is amazing. So the day I met her, she started coming to the support groups when we had it at Kaiser. And oh my gosh, she goes, I don't want to do dialysis no more. I want to transplant. I want this. And she told me everything she wanted. And so I said, okay, well, let's do this then. Not everybody has the support she has, but she has great support and her family members. And with that being said, she really took the torch and got everybody involved on that torch to get to where she's at today. And I have to say, she had a pretty good journey, and she's doing good now, but I'll let her share that part. So I thank you all, and I just want to give her a certificate.
Thank you so much.
We're proud of her. This is our first year doing this, so it is of acknowledgement, recognition to her strength, her courage, and unwavering dedication throughout her journey. Her successful kidney transplant represents not only a medical milestone, but a powerful testament of resilience and hope, a second chance of life beyond dialysis. May the path ahead be filled with continued healing, new experiences, and lasting wellness. Our thoughts and prayers with the deepest respect and admiration for you, Anna. This is for
Thank you
you.
so much. The only thing I'm just gonna tell everyone that is going through this, don't lose your faith. Because that's the only thing, if that's the last thing you can lose, your faith. Because if you got faith in God, you have faith in everybody else. I went through that journey, dialysis 7 years, finally got my transplant, and I'm so happy about that I could just continue doing my exercise, doing whatever I need to do to take care of this kidney that God gave me. And thanks to Carol with all the information that she gave me. And I went through this journey with everybody, my family, my son, my daughter, my sister that's over there right now. And they helped me out a lot. And don't lose your faith, because we all need it, and we have to give thanks to God for what we have. And He's giving us another day. They give you one more day, leave it to the max, because who knows, right? So it's one day at a time. Thank you, everyone.
Anna, that is just awesome. Awesome. Okay, at this time, I want to bring up a buddy of mine, helps me every year. A lot of years he's been, wherever we've been doing this, he helps me with all the questions coming in online and the doctors and this and that. He was on dialysis for 22 years. And let's just say he says, I'm walking proof that anyone can get through this. Just reach out to support your group and we'll get through it. He has some very exciting news that he wants to share. So can I bring up my buddy, Rod Brown? Come on, Rod.
Yeah, he's acting shy, but once you give him the mic, watch. Okay. So anyways, Rod, I met Rod because of his wife, his better half, okay, related wife. And I'll tell you something, he didn't want nothing to do with us. His wife said, take me there, take me there. She was so involved with the foundation, he slowly but surely started coming with us. And then he told me, I'm comfortable doing dialysis at home. I don't want a transplant. But he did it. He did it. So I am one honored person to give this award to you because, wow, we went along. There's a world out there in the healthcare, and when they tell you, you have to respect everything they say. But when they tell you, you're not ready yet, you can't believe that all the time. You have to go by your own will. You have to know that, you know what, I'll never be ready for this, but I have to try. All you could do is try. And that word try, he finally listened to it. And I'm just so grateful because I know it's tough, but you've done it, Rod. He's lived a great long journey with kidney conditions.
My date was, I got my kidney transplant on December 10th. So yes, early Christmas present. And now it's hard to figure out what to do with my time since I'm not doing dialysis 20 hours a week. So, but like Gary said, it was a 22-year journey. Now I'm on a new journey. What to do with my time. But I'd like to thank you all for being here. And this is a blessing, and I hope to take care of it. Thank you.
Okay, so we'll get things going with our first keynote speaker. I'm just gonna, Dr. Anthony, just real quick. Give me 1 second. I just want to tell a couple things about you. Dr. Anthony has a tremendous amount of titles that go well beyond just an MD. He has 26 years of healthcare industry experience and is board certified in internal medicine and nephrology. He is a physician executive and leader with a proven record of building and leading healthcare organizations and medical startup companies. While he has deep expertise in other areas of medicine, Dr. Anthony is passionate about bringing a greater awareness to individuals on how critically important kidney function is to our overall health. He has penned several articles educating the public on renal kidney disease. He has co-authored a textbook chapter on renal toxicology in Gulf Franks Toxicology. He has a podcast, Cool Beans Podcast, www.coolbeanspodcast.com. Did I get that right, Doc? All right. Where he discusses various diseases as they relate to kidney disease. Further, he teaches nurse practitioner and physician assistant students through clinical rotations in his office practice. In fact, he served as associate medical director for the Charles R. Drew University Physician Assistant Program in recent years. So let's bring up the doctor now, Dr. Vincent L. Anthony.
First of all, that up here, Carolyn, thank you very much for having me back this year. This is a board. Thank you guys. MC, thank you as well. And I appreciate everybody coming out here. I'm a little subdued this morning because I'm tired, but I wasn't going to miss this for the world. I've been up all night taking care of kidney patients. So I wanted to be here to share some of these things, some of the information that I have with you. I'm going to try to do it in 30 minutes. But some folks know me. I get passionate and I keep it moving. I'm going to dedicate this talk to my mother, who passed in December, right after Rod got his transplant. She's the one who encouraged me to keep doing this. It's something I didn't want to do without her, but here we go. Now I get a little animated and I like to walk back and forth and this kind of thing, but we're hearing a lot of information about value-based care. And one of the things that strikes me is when we talk value, a lot of times we're not talking about from the patient perspective, and it drives me insane because value truly means what does it mean to that individual, not just society. That individual is part of society that needs to rally around that person. Now, one of the things making this very important is that the cost of renal disease is going way up. So there's a threat to cutting certain services. So the Kidneys Quest Foundation actually fills a lot of gaps that you guys don't realize we are losing legislatively because of the cost. So there are different modes of how we need to care for patients to make it more cost effective and make it better for society, but still make sure that that patient understanding and that patient's care is paramount. So I put these slides up. Why does kidney care need to change? Well, really, we got the mandate in 1972 about everybody being able to get dialysis on the Fed's dime. That was President Nixon did that. But they've walked that back ever since as the cost grew and grew and grew. One of the things that statistically happens is that dialysis patients, 5 to 6 years, if you have diabetes, 5 to 6 years is the average lifespan across the country, which is terrible because it's been that way for 40 years. So with all the new technology, I'm sure you guys who are on dialysis for long periods of time see the new machines that come out, the new tubing that comes out, all of these different things. But the statistics haven't changed because we haven't focused on the patient first and foremost. What happens at the bedside with the doctor is most important. A lot of times, kidney disease affects millions of people. So we gotta fix this issue in terms of how we mitigate kidney disease before it happens and slow the progression and build dialysis systems that actually treat the patient well and keep people healthy and well. That's the point. It's not just treating a disease, the whole patient needs to be well. So patients often see many doctors. Care becomes fragmented and confusing to patients and to doctors and to nurses because everything is siloed. The dialysis companies say they want to do this. The doctor's office say they want to do this. The hospital wants to do this. You know, if someone's living in a facility, the skilled nursing facility wants to do something else. At home, we don't evaluate what's going on at home. So there's a lot of disconnect that's in the renal care system, and I'm gonna fix it. Too many patients end up in the hospital for preventable problems, and I can get into that later. We need a system that focuses on keeping patients healthy. I have up there, but I just said well, and that's what I mean. So the reality is for many kidney patients is that they have a whole bunch of medications, some of which not all of them are needed. They're duplicates in a lot of ways. But as I'll get into later, the physiology changes in a dialysis patient or a late-stage kidney patient such that primary care physicians really don't understand the details and the minutia that go into that care. So that's a lot of times why we just keep adding medications. Hospitalization for fluid overload or infections, emergency room visits when a problem worsens, meaning there was a delay in care in the outpatient setting, that people don't recognize that you have got to move with kidney disease. You've got to be able to execute a strategy immediately. You don't have time to wait for an authorization. It'll, you know, and a stat authorization, which means we get it right now, the law says that that's 3 days wait time. Now, what dialysis patient can wait 3 days for some stuff, right? Without having an outcome that sends you to the hospital, right? That's a stat. That means quick. That means now. Regular authorization is upwards of 21 days. Anyway, I'll make my point later. I'm going to try, Ms. Linda, to keep it short. So we need to stress a system that includes patients, includes their family. You did this on purpose, so I can't walk. But we need a system that includes patients and their families and make sure that those patients and their families are supported. Again, that's something that Kidneys Quest is doing that you guys think it's normal because you see it here. But out there, it does not happen. Patients are on an island a lot of times. Their families can't get the support they need to support their loved one with this condition, whether it's late-stage kidney disease or end-stage kidney disease. So it's really important that we change this. So this is the traditional model. Doctors get paid for each visit or procedure. The system rewards volume, meaning how many patients I see, versus outcomes, all right? Limited coordination between specialists, which I just said, kidney specialists may have at least 3 or 4 different doctors. So how do you coordinate those doctors around one thing? Preventative care sometimes takes a back seat to crisis care. And in my dialysis population, unfortunately, a lot of the dialysis patients don't even get a screening colonoscopy on time because it's not thought about, because they're dialysis patients and the primary care doctor doesn't really see them. And so things get slipped through the cracks. So what is value-based care? It's focused on outcomes, supposedly. Doctors are rewarded for keeping patients healthy. Healthy, not well. Healthy, to me, is checkbox. That's why I left it healthy, because I wanna go into that. There are some metrics that happen in the literature that have been adopted by organizations, which are true and good. They're good. They have prolonged people's lives a little bit, but they don't go the extra mile. They don't look at, are you really well? Can you function? You know, can you walk yourself to the store? Are you getting the right food? We'll get there, all right? Coordinated care across doctors, hospitals, and clinics is what value-based care adds. That's why you see, or you guys may have the experience that a health plan will have 50 people calling you. If you have an HMO, they'll have 50 people calling you. You doing all? And they'll ask you the same doggone questions. And you're like, how come y'all didn't share this information? Anyway, the goal is better health and fewer hospitalizations. At least that's what we're trying to get at. So it's different. It's not based on volume, it's based on outcome. That's a big deal. So the whole country is trying to make this shift, not just in the kidney space, but everywhere, because it's more cost efficient to the public, and it's better for patients, particularly keeping patients out of the hospital. Hospitals don't like that, but they need to be doing something else, in my opinion. So why value-based care matters to the kidney patient? All right, first of all, I don't know if anybody knows the statistic that there are 5 different stages of kidney disease. Everybody knows that in this room, right? 1 through 5, 5, okay. I see some looks. Okay, 5 stages of kidney disease. Stage 1, 2, 3, 4, and 5, based on your kidney function. Most times, people don't even find out they have kidney disease until stage 3, which I think is a travesty. But nonetheless, that's what it is. In stage 3, there are more kidney patients in stage 3, and we'll talk about this a little bit in my next talk. There are more kidney patients in stage 3 than any other stage of kidney disease. More patients die at stage 3 kidney disease than die in other diseases. Now, the percentage is higher in later stage kidney disease, but more patients pass away at stage 3 because they don't get to the nephrologist on time. And it's thought that, oh, well, it was a heart attack. Oh, it was a stroke. It was something else. But if we had taken care of that kidney problem early at stage 1, none of that would have happened, okay? So kidney patients have a high hospitalization rates. Many complications can be prevented with close monitoring. Coordinated care improves outcomes. Remember, that's the health plan calling you 50 million times. But there's a better way to do that even, okay? Preventing complications improves the quality of life. Absolutely. Anybody would agree with that. So this is what me and my team have come up with. We've come up with an IPA model that's a true IPA model for kidney patients, right? Now, most IPA models are for primary care, all right? Y'all know how this works. I'm going to teach you how it works. Open my coat. Medicare, payer source. They pay the health plan, okay? Then the health plan contracts, with doctors groups, right? Some of those doctors groups are called IPAs, right? And so that IPA then is responsible for caring for the patient. The bedside care is the doctor's group, right? But again, it's fragmented. It's fragmented care. So we have a physician network that's focused on kidney disease care first. Everybody's heard of the American Heart Association, right? Now, you know the American Heart Association has a diabetic component. They have a hypertension component. They have a cholesterol component. So they have everything under anything that's related to the heart. Well, that's what we need to do with kidney disease. We need to do the exact same thing because guess what? We encompass heart. So all of that stuff that the heart people do, that's our realm too. Because the kidney is a ball of specialized blood vessels. And cardiologists hate when I say this, but if you go back to look at the advent of the kidney specialty, nephrology, it was the smartest cardiologist that created that specialty because it's blood vessels, right? So we do all of that because of what the kidney does. And it's more important, particularly as you get in a later stage and the physiology is changing. Every cell in your body changes when you have a kidney problem. Every cell in your body, how it metabolizes, what happens to it. the time that the cell turns over, meaning our cells are constantly dying and having more cells rebirthed. That changes. All of that changes. So your whole makeup changes differently when you have kidney problems. So a nephrologist in our model coordinates the entire care. So the nephrologist becomes the primary care doctor. All right. So none of this, we don't know how to handle the kidney disease, just send them to the ER. That's what happens. And you guys gets the brunt of that. You just wind up going to the ER for nothing. There's no coordination going to the ER. So when you get to the ER, there's nobody really there that the primary doctor picks up the phone and calls the ER doc and says, hey, look, I'm thinking about that. Just look for this, and this, and then call me back. It's nope, get the patient in there, zip, we don't know how to take care of it. We don't want to get sued. So guess what? Go to the hospital. Then you get admitted to the hospital. Then you get admitted to the hospital, you see a primary care doctor on the floor. Primary care doctor on the floor says, oh my Lord, we need to get a nephrologist. So you get a nephrologist. Nephrologist says, I really don't know this patient. We need to do dialysis now, if it's a dialysis patient. Or we need to do this. So the patient winds up sitting there for like 3 days going, I feel fine, guys, but I understand. Sometimes it's not that way, but sometimes it is. All right. So a nephrologist who understands every cell in the body change, who trains that way, then runs the whole show. Because guess what? We had to train as primary care doctors before we became subspecialists. So we do this. It's just dormant, okay? And it's better for the patient because I'm seeing you like very frequently, okay? Focus on prevention, monitoring, and education. And prevention in a kidney patient is different. For instance, you guys have heard of the statin drugs, anti-cholesterol medications? Okay, so statin drugs are good for everybody, right? Dialysis patients, there's no benefit been proved in any literature. But we keep people on it if they were on a statin before they became a dialysis patient, just because no harm, no foul. But we should not be starting dialysis patients on statins when there's no proven benefit. I joke with people, and this is a joke, I'm a professional drug dealer, but I don't like to give pills unless I have to. So I don't want to start a statin in somebody who seems okay, that I know that there's no proved benefit in the literature, right? So those are some of the nuances that I'm talking about that a kidney doctor knows that other folks don't know. Am I good on time? Yeah, okay. So this is the nephroextensivist concept. This is what we call our nephrologists who are primary care doctors. We call them a nephroextensivist, okay? And so the nephrologist acts both as a kidney specialist and a primary care physician, coordinates all the care through the working closely with the dialysis centers and all of the specialists and hospitals. Again, the nephrologist sits in the middle, and the nephrologist practice sits in the middle of this complex physiologic patient. We ensure all aspects of kidney care and primary care are aligned. Again, there's going to be no missing screening exams. Some of my ladies hadn't had a breast exam in like 5 years, and that just drives me insane, only because they're late-stage kidney or dialysis patients. It gets overlooked. And what's sad about that is that cancers in kidney patients happen more frequently than in other populations. And so those screening tests are crucial if you have kidney disease. And you need to be asking for them. Even if you have stage 3 or 2, you need to be asking for them, because that's the way the cookie crumbles according to the literature, okay? So we also help manage the complex medical conditions common in kidney patients. So diabetes is one. I'm gonna just give you an example. When you have late-stage kidney disease, it's harder to control your diabetes. So what winds up happening is people will put you on 5 different medications. We can't get the blood sugar controlled. But a kidney doctor knows the kidney is responsible for how insulin works and how fast insulin works. So I'm just going to adjust the type of insulin I give. I'm going to adjust the type of medication that I use. Some of these medications should not be used if your function is less than 40. We'll get into that later. But they get prescribed anyway. So now, just like I said, the drug dealers are just drug dealing. They're not really looking at, is it effective for you? Every drug is a poison. It can be used for good or bad. That's how God designed our bodies. You know, we need to be in balance. So that's all we do as doctors, is put things back in balance. We're not curing anything, in my humble opinion. We are putting things back in balance. All right. So this is what the team looks like. So yes, I put the nephrologist at the top on purpose. The dialysis nurses and staff really should not come second. The care navigators and support staff, which is down at the bottom, comes second. I had a hard time redoing the slide, so I just would say I would tell y'all that. So the care navigators are most important, because the care navigators consist of case managers or care managers plus a nurse practitioner or PA who works directly under the nephrologist, right? Now, why is that important? Because usually the nephrologist is a specialist way over here, and then there's primary care here, and then the health plan has care navigators. So the primary care doctor doesn't even know what the health plan wants to do, and the health plan doesn't know what the IPA, which is the administrative part of the doctor's group, doesn't know what the IPA want to do. So you got a case manager at the IPA, you got a case manager at the health plan, the doctor's office is clueless, the primary care doctor's office is clueless, and the specialist office is clueless. But we're the ones writing the orders. We're the ones trying to coordinate care. Makes no sense, right? No sense. But this is our system as it exists today, which is why you have these gaps in care, particularly for kidney patients. And I'm not going to stand for it anymore. All right. So primary care coordination is through the nephrologist. All right. So all of those screenings I'm telling you about, us managing the diabetes, managing the high blood pressure, managing the cholesterol, all of that stuff comes under the auspices of the nephrologist and his or her team. The care navigators consist of those people. And by the way, a care manager is an RN. Okay. LVN or an RN. So these are people who've been on the front lines, who know clinical medicine, who have seen people. And what they need in the hospital, out of the hospital. You know, some of them do home health and all that kind of stuff. So these are people who are the most knowledgeable about caring for someone. You know what happens at a health plan? I was medical director of an MSO, management service organization, so I know what happens at the health plan level. What happens at the health plan level is if you need an authorization for something, it goes to the utilization department. The utilization department is not made up of clinical people. It's not made up of clinical people. So they get on the computer, they have this thing that they look, they say, the doctor wants to do this, that, and it doesn't match that. No, he can't do it. What? Anyway, I'm getting off on a tangent. Let's keep going. You can tell I'm passionate about this because it's a problem. It's been a problem for 50 years. You know, it was said that I have done this for 26 years, but really, if you go back to my School of Public Health, I've been doing this since '94, looking at these kinds of problems and how systems are set up in society. It just so happens I'm passionate about kidney because it affected me and my family and my friends directly. I was supposed to be a heart surgeon. I was real good with my hands, but God had other plans. All right? So nurse practitioners and physician assistants, they come in this big as well because they're part of the care navigator support staff, but they also have other roles. They take on the role of helping the physician clinically. All right? If we were to take all of the nephrologists in the country and then all of the 37 million kidney patients in the country, each nephrologist would be responsible for like 13,000 people. So I'm one of those doctors who says, you know, we need nurse practitioners. We need PAs. We need them, but I'm not going to let them run amok. All right? Which is what happens sometimes. Anyway, so we have programs that are designed around what happens at the bedside for dialysis patients particularly, but for stage 4 as well. All right, fluid management programs. Yeah, everybody does that. It's true, but they don't do it the way we do it. Arrhythmia monitoring programs. They don't even have EKG machines in dialysis clinics. If y'all go to a dialysis clinic, look around and see if there's an EKG machine. None, okay? That's a problem because most people go to the hospital because their heart speeds up real quick and they get short of breath and people say, boop, go to the hospital. Whereas if we had an EKG machine, we could look at least a strip and say, okay, this is what we need to do because this is an arrhythmia. We need to slow our rates down. We need to do something right at the dialysis machine, not just regulate or subjugate somebody to go into the hospital who you know is going to get admitted because they have dialysis written all over their forehead. So the doc is like, I don't want to get sued. All right, infection prevention programs. Everybody says, yeah, we do that. Not like us. Vascular access monitoring. How does vascular access get monitored usually? In the dialysis clinic. That the vascular access is, do they have a catheter here that takes their blood and goes to the machine and comes back, or do they have an access in the arm that takes the blood out and gets it back? So those things clot sometimes. So the way we monitor, now we got all of these bells and whistles, and Fresenius is good. I must say, Fresenius is good about doing vascular access this way. There are things on the machine that we can twist and say, the blood flow is getting slower in the access. We might need to do something. But what winds up happening? Nothing. And then it clots, and then everybody has an emergency, and we got problems. The other thing that happens is that the vascular surgeons, any vascular surgeons in here? Okay, good. Some of the vascular surgeons get a little greedy, and they say, you need to come see me every 2 months so I can check that access out, make sure it's working right. For what? We're trained to do that as nephrologists right at the bedside by putting my hand on the access. There's certain things I feel for. There's certain things I listen for. That if you've been trained well, I don't need you to go to the vascular surgeon every 2 months. I can tell the vascular surgeon when it's time to go. So therefore, again, in our program, the nephrologist coordinates all that. So it's not just shipping somebody to the vascular surgeon, because a lot of times, some vascular surgeons, not all, some will want to do a process where we go into the access and look at it. Just so that's an extra check bill that they can bill, right? But anytime you enter that access, you're causing an increased propensity for it to narrow and clot. So you don't want to do that all the time. So let's do some non-invasive methods. Like I say, vascular access monitoring, they don't do it like we do. Medication optimization. I just told you there are some medications that people don't need that we get rid of. Detailed advanced directive and living will planning. This is a big one in my book. I'm tearing up a little bit. I had a patient who decided, Doc, I've made my peace with the Lord. And she wanted to go. And we got the family together. We sat down. We talked about it. And it was the right thing to do for her. So not only did we get a chance to talk about it and really hash through her wishes, but it was respectful. Dialysis patients sometimes don't get respected from the staff at the dialysis clinic, from the doctors who are making rounds. They don't get respected. And that's a big thing in my book. I grew up a little different. Respect is a big deal where I come from. So with her, we had her family around, and she was able to make that decision, and we were able to make sure she transitioned well. I was off, and she was, if you don't get dialysis, it makes you sleepy. She got sleepy, and somebody dialyzed her. And that was so disrespectful to what we had already planned, simply because I was off. Nobody read the chart. Nobody read what I was doing. So we have a system for how we're going to do that for everybody. And it doesn't have to, we don't like to ask people right when it's time. We like to have it way ahead of time. So families involved, caregivers are involved, we're involved. We know what the wishes of the patient actually are. And that's a big deal to somebody. That's a big deal to somebody. That's that respect piece. Am I still good on time? I feel like I'm going over. All right. So how do we prevent hospitalizations? We have these various programs that I just laid out. We identify fluid overload, arrhythmias, dialysis access complications. We do all of that stuff. Now, how is this a benefit to a stage 4 patient? All right. Now, remember, there are 5 stages. Stage 5, you need dialysis. How does it benefit somebody who's late stage? Well, we slow the progression down. There was a study done in 2 studies actually done in 1998. One was published in the American Journal of Medicine. The other one was published in the New England Journal of Medicine. And everybody says New England Journal, and they go, ooh, it must be a good study, right? Well, it said back then we didn't have GFR. We didn't have function rates. We didn't have 5 stages. We had creatinine levels. And they said if a creatinine got above 1.4, which was the cutoff at that time, 1.3, 1.4, 1.4 for men, I believe it was, that people should see a nephrologist at least once. And just seeing that nephrologist one time slowed the progression of kidney disease. 1998, we knew that. How come nobody implemented that? How come nobody instituted that? Now we have GFR. Some labs won't even tell you that you have a kidney issue until you're in stage 3. It's a travesty. Anyway, I'm gonna keep going. Preparing for future treatment options, that's a benefit. Because at stage 4, we're preparing for the eventuality. We're still trying to slow it down, but we're preparing for that eventuality that you might need dialysis or a preemptive transplant, meaning you don't go to dialysis, you go get a transplant before you get to dialysis. That is one of our goals, okay? Education on diet, medications, and lifestyle. Y'all get, let me just explain. The dialysis clinic, the dialysis patients, if they're in the clinic, they get that stuff with the dietitian running by. Here, read that. And they keep it moving, okay? Sometimes you'll get a nice dietitian, they'll sit and talk to you for a hot minute, but we have continuous education that I'm so happy we're working with Carolyn, because we're gonna work on this together in terms of how we institute continuous education right here, but then also how do you get back to your doctor's office and ask that question? Hey, whoa, doctor, slow down, come here. Let me ask you something, right? None of this running stuff, okay? Early referral for transplant, all right? That's what benefit to stage 4. Stage 5, you really need dialysis. So all of these things that I said for stage 4 actually hold, but we want to avoid emergency dialysis. Emergency dialysis is the bane of my existence, because we wait, then it's an emergency, and people say, I don't like dialysis. Well, we started too late, number one. And so now everything is emergent. And when everything is emergent, right? So the patient doesn't feel well, all kinds of things go wrong. So the benefits of stage 5 working with us is that we're gonna look at that, and we're gonna have things started, right? And this is the way, my hope is that this isn't just us doing this. We wanna take this across the country. We want this model to be across the country, because the payer models that we've had in kidney disease are horrible for the doctor-patient relationship. They're horrible for it. It's volume driven on the one end with straight Medicare, or if you're in a medical home or an ACO style model, the nephrologists get this much for doing not everything to the patient. They get a little bit more than Medicare for not doing everything with the patient, so they're walking around like, oh, okay, cool, I'm making more money. But they're not doing anything else. So why you ain't doing anything? I mean, there's a risk reward for something, right? Anyway, see, I keep digressing. All right, so we want to reduce hospital visits. We want more personalized care. When you have your nephrologist as your primary care doctor, that's cool. Now, some people are very loyal to their primary care doctor. They've been with their primary care doctor 30 years. And you know what I say? I say, Kudos to you. Because that primary care doctor, if you have stage 4, 5, or end-stage kidney disease, that primary care doctor prevented you from dying in stage 3. Because remember what I said at the beginning. Most people die at stage 3. So I tell my dialysis patients, you are fortunate. You have no idea, right? Statistically, you have no idea. So I say, give that primary care doctor a pat on the back, but now it's time for more expertise. You can come see us or your nephrologist. We want to join us as well. You can see your nephrologist for all your primary care stuff. And then you've been with your doctor for 30 years, your primary doctor, go say hey every now and then. What's happening? How you doing? I'm still around. Thank you for everything you've done for us. But now your physiology has changed and you need more expertise, right? So that's what we're trying to support here. You know, it's not a battle against primary care doctors. And that's not really what I'm saying, because I do primary care in my office still for non-kidney patients, right? I believe in the mantra that primary care should be the gatekeeper for everything. I believe in that. So I still do it. Okay? But this here too, supporting families and caregivers is huge. We need to make sure we do that. So overall, we're going to improve the quality of life. We're going to have fewer hospital stays, better symptom control, stronger support systems, because it's going to be a webbed network around the patient, not a webbed network around the authorization. Okay? More time living life outside the hospital. This is what I mean by well. Something very simple that we'll do, and I'll give up the tapes on it. He's recording it. Somebody's going to steal my idea, but it's all right, because we want this to go across the country. Something very simple that the literature has told us for years on elderly patients. If I give you a grip strength, all right? Have you guys seen those things where you're working out your wrist? If I can tell your grip strength and there's a certain pressure that you can squeeze up to, if that changes over time, that gives me a proxy to your functionality, whether you can walk and do the things that you want to do, whether you can handle some of your ADLs, which is activities of daily living, like brushing your teeth, washing your hair, cooking your food, this kind of thing. Just this little thing. I can give that to everybody sitting in the chair and be done in 20 minutes. But I've gotten some valuable data. That's what we do, right? And we're going to use that data in order to make people's life outside the hospital better and well, all right? So the vision for the future for us is a healthcare system centered on patients, not payments, okay? Right now, we're centered on payments because everything costs so much. But doggone it, if they let us do our thing and we get down with the patient and educate the patient, they will save so much money, it's ridiculous. I have an MBA, I know, okay? So just all they got to do is crunch the numbers properly and stop worrying about how much we gonna get off of the top. That's what happens. How much we gonna get to our shareholders? You know, the shareholders will make more money if you let us do our thing and really care for patients. And then obviously we got to do some other things with the legal system, because the legal system scares a lot of physicians into just doing everything so they don't get sued. And that's not right either. Okay. So there's a Venn diagram of 3 different circles that don't overlap like they should. The payer diagram, the clinical diagram, and the legal diagram. They don't match, which is why we have the mess that we have. So doctors working together as one team with the nephrologist at the center of the care. Prevention rather than crisis care. I don't like crisis care. I hate people starting dialysis late. I hate getting called in the middle of the night because we didn't anticipate that someone wasn't going to make it from Friday to Monday. We didn't anticipate that. I mean, if you're looking at the patient, you can kind of see that. You can see which patients are progressing a little bit, what you need to do a little extra for. But that's why we have our system built around care managers, nurse practitioners, PAs, and the doctor, him or herself, okay? We're not over here on the sidelines, all right? Kidney patients living longer, healthier, and well lives, that is the big deal, okay? So kidney care works best when doctors, patients, and families work together. I mean, in this setting, that's kind of a given. I hate to tell you, out there, it's not. Out there, it's not. Some folks think that families can never be sophisticated enough to take care of kidney disease. Anyway, don't get me started on something else. K-Care IPA model is designed to keep patients healthier, prevent complications, and improve quality of life, all inside the value-based models. But again, we've flipped the value-based focus. The value-based focus is on the doctor-patient relationship, what happens right there at the chair. That's where our value comes from, not how much money did we save. Oh, we're going to save some money, no doubt. But if we focus on that chair, or you're in my exam room, and we focus on making sure I have everything that I need to do with what I do for patients, they're going to save money. Everybody's going to be happy. People are going to live longer. People are going to live well, and we're going to be good. All right, so we have a wellness network where we just teach and that kind of thing. Again, we're going to be partnering with Kidneys Quest to do a lot of our things because we don't want to overlap too many things. And it's better to go with the lady who's been doing it much longer than we have. You know what I mean? I can add my 2 cents to it, and I'll be giving some of the lectures for Kidneys Quest as well. But we do have our own network that we're going to start putting out newsletters and that kind of thing. We're on LinkedIn, and I think we're on Facebook too. And what we like to do is put out little questions. Both my parents were educators, so I got it honest. I want people to learn. Okay? All right. So now I'll open it up, I guess, if I have time, for a couple of questions. Okay. Yes, ma'am. Yes. Oh, wonderful, wonderful. So the question is young lady was diagnosed with diabetes a little while ago, and she wants to know what questions should she ask her doctor, or is there a question she should ask her doctor to make sure she prevents the kidney disease? And that's an astute question, more than you know, because diabetes is the #1 cause of kidney disease in this country. All right, the #1 cause. So you got to know about your diabetes, #1, okay? But UACR, urinary albumin creatinine ratio. I use both of them, so I'm trying to get you the one you need for diabetes, okay? So A1C, yeah, A1C, yes, but there's a reason you look at the A1C. I have a slide on one of my other talks that tells you exactly what you need to know for blood pressure, cholesterol, A1C, diabetes, and what your kidney numbers should look like, okay? I keep threatening to create that into a card, but I keep forgetting. I need to do that and just give it out to the community because it's so valuable. You can walk in and say, hey, doc, what are my numbers? And then you can look and say, oh, I'm a little off here. But UACR is one. Your blood pressure is the #1 thing in diabetic kidney disease that you need to look at. People think it's the blood sugar. It's not. Blood sugar is second. Diabetes causes kidney disease, #1. But when we're treating it, we want to maintain a healthy blood pressure. And what does that look like? 130/80 or less. And I got some slides to prove that, but there are a lot of people out there, primary care doctors. I'm not punching the primary care doctors. Please don't think I'm doing that. Kidneys are very specific, and it just so happens the kidney is the second brain. So it hits every cell in your body, it hits every organ, it hits every disease. Your management of every disease known changes, whether it's cancer, whether it's diabetes, whether it's COPD, whatever disease you have is made more difficult to manage when you have kidney disease, which is why a kidney doctor needs to be at the helm, right? So blood pressure is #1, 130/80 or less. If you have protein in the urine, okay? Protein in the urine is that UACR test. That's urine protein. Ask about how much urine protein I have, doctor, okay? So blood pressure, urine protein. The third thing you already mentioned, your hemoglobin A1C. For people who have protein in the urine, hemoglobin A1C less than 7%. 7. So if you got 7.2, you don't cut the mustard, okay? Those three things you can take away with you right now. Now, there are other things like eating antioxidant foods, okay? Nuts, berries. I want you to stay away from citrus because citrus has antioxidants, but citrus also has straight glucose, particularly oranges. Okay? So come on. Not everybody has diabetes. Come on. Cut us some slack. All right. So anyway, those are the kinds of things I want you to do because antioxidants are in all of those foods. Apples, a lot of different types of apples have antioxidants in them. The kidney tissue is under low oxygen. So if your oxygen in the blood is 100%, at the kidney level, it might be 70%. So it's already low. So if you get a little oxidation or oxidation, I liken to detergent. Like when you put detergent in the washing machine and it bubbles up, and that's an oxidizing reaction. Okay? So that kind of bubbling is happening at the tissue level. So if you eat antioxidants, it prevents the damage from the soap bubbles, so to speak. Okay? So those kinds of foods you need to eat, particularly, and that would be healthier for the kidney because now it allows the kidney to stay at that 70% and not drop all the way down to 30% where cells start dying. Okay? So those four things, I could give you more, but I want you to remember those four things: blood pressure, hemoglobin A1C, UACR, and eating antioxidant-rich foods. Okay?
And do you have a list of all the antioxidants foods that we cannot eat or that it can help us? Because a lot of people here.
No, I know.
I bet would love to have
No,
that.
no,
Me, myself, of course.
we do, but here's the thing. And when I have patients in my office, food is spiritual and cultural.
Yeah.
Right? I grew up in Mississippi. You're not going to tell me I'm not going to have some pudding every now and then, some peach cobbler, you know what I'm saying? Nobody's going to tell me that. So I do things from a cultural perspective. And the earlier your kidney disease is, the less you have to change your diet. Does that make sense? The less you have to change your diet. So if you have stage 2 kidney disease, you can be eating one thing, but if you have end-stage disease, you shouldn't be eating something else. However, this is still being recorded. Hold on. Nephrologists gonna hate me when I say this. So let's say I have a Latin man who is 72 years old. He's been eating tortillas since he was 1. He's been eating beans since he was 2. And now he's on dialysis and has diabetes. I'm gonna walk in and I'm saying, you can't have that anymore. You gotta cut it out. No, I'm not gonna say that. I'm gonna say, hey, listen, this is how we're gonna do this. And I'll whisper to him, hey, we're gonna do this, we're gonna cheat, all right? You like your rice and beans? Good. So eat your rice and beans the day before you go to dialysis, just 1 day a week, and here's your portion size. Don't tell nobody. I'll adjust your dialysis to help remove some of that crap. But you can't do it all the time. But I'll negotiate with you because him tasting the rice and beans, psychologically, he's still part of community. Psychologically, he's still able to do what other people do. So when I was in New York, I had some Jewish patients, and they were like, hey, doc, Seder's coming up, man. I need to do extra treatments. I'm like, cool, not a problem. Let me go hook that up. Because Seder, they have a feast. They're drinking, they're eating, they're doing all this stuff. We made a plan for portion control of each different types of food, but I let them do it. They participated with their family at a holy holiday. That's who I am. I treat your disease inside of your life. I don't want you to change your life for this doggone disease. It's a different way to look at things. So we would have to see what your kidney function is. We would have to see what your blood sugar levels are. We would have to see all of that stuff. And then we would make a plan. we would make a plan. So don't go out and say, oh, I can't have this because I have diabetes. That's going to be true with a lot of the stuff.
Portions more than anything else. really.
More, yes, but it's going to be true with a lot of things. But again, I had an uncle who had diabetes, and he felt like he was just outside. He couldn't come to family reunions. He couldn't, I mean, I don't like that. I remember that. So let me work with you. I'm the professional. So if, one day every 2 weeks, you want your rice and beans and you're on dialysis, cool. Let's keep it quiet. Let's tell me, let's change. Let's work together, right? So I've beaten that dead, yes.
Hello, doctor. Thank you so much for your presentation. So right now you just addressed the labs and things that we need to look at. So it was blood pressure, number one. Number two, the UACR ratio, and you said that it should be less than 7%?
No. That's the hemoglobin A1C should be less than 7%.
Okay,
The UACR usually comes in 30 millimoles, 300 in that range, but we need to see what it is, okay? Because the UACR will also change the flavor of the kidney disease that you have. So if you have stage 2 level and you have less than 30 protein, that's one thing. If you have 30 to 300, that's another thing. If you have over 300, that's another thing. So we as physicians, we as nephrologists are looking at it that way, okay? So you need to know what that number is.
okay,
And it's just how much is coming out. It's not a percentage, it's just how much is coming out.
I see. And then my question was, in terms of the kidney disease, you said that there's 5 stages. We want to prevent kidney disease. So stage 1 and 2, what are those?
Okay.
And are those also to prevent stage 3, which you said usually requires, that's when you get diagnosed and people typically die. So
Yeah, so that is I'm glad y'all got that message. It's a big message, and I'm trying to get that word out, so you got it. Now, stage 1, let's just go through what the stages mean. So there's something called eGFR or GFR, but I just like to tell my patients function. And then when I get on the board, I write F parentheses X, and they're like, oh my God, he's going back to math class. No, but it's function, okay? So function above 90 is considered normal, okay? And there's some nuances to this. So I'm just teaching you this part, but there are nuances to it. So above 90 is normal. So stage 1 means that you have above 90, but there's something else going on. You have microscopic blood in the urine. You have protein in the urine, what we just talked about. You have one kidney. You have a horseshoe kidney. You have something else anatomically wrong with the kidney or the ureters or the bladder. That is stage 1. Now, the reason we did that, and KDIC did this a long time ago, is that you're at increased risk of progression. Even if your GFR is normal when you have these other things. So we should be intervening as nephrologists saying, man, okay, stage 1, period. We need to do something. So if protein's coming out in the urine, I'm not going to wait till you get stage 3 before I start attacking the protein with different medications. Now, I may not give you a huge dose of a medication like I would for a stage 3 patient, but I'm going to do something to slow that progression down, okay? So stage 2 is 60 to 89. That's the eGFR again. Stage 3 comes in 2 flavors, stage 3A and 3B. Stage 3A is 45 to 59. Stage 3B is 30 to, what did I say? 44. Brain fart. Okay, so, but you see, if we wait till you're at stage 3 and you're supposed to start at 90 and you're now in stage 3B, somebody dropped the ball somewhere, right? That's not on my watch. That's not going to happen. With any of the docs that we bring into our group, it's not going to happen, right? Because, oh, let me keep going. All right, so we got stage 4, which is 15 to 29, and we got stage 5, which is less than 15. And really at stage 5, you need renal replacement therapy. You know, I don't like to call people, oh, you're a hemodialysis patient. Oh, you're a peritoneal dialysis patient, 2 different types of dialysis. Oh, you're a transplant patient. We can say that short term, but in my mind, as your physician, you are an end-stage kidney disease patient. Because if I use all 3 modalities, your lifespan improves. If I know the break points, right? If I know the break points, this brother here was one of the few patients that lives 20-something years on dialysis. Usually there's a change that we go through. So you go to hemodialysis, then you go back to peritoneal dialysis, then you go to transplant, then you come back to hemodialysis, then you go back to peritoneal. So to me, everybody's an end-stage patient because I'm looking at longevity, right? So I'm not, you know, if someone does hemo first, I'm still looking at, okay, if the hemo fails, what am I going to do next? I don't care if it fails in 10 years. What am I going to do next? Okay? So that's why those numbers are important for us as kidney doctors, right? And even the early ones, because the early ones, if you got a little bit of protein in your urine, but your function is normal, guess what has protein in the urine? A cancer. The kidney can say, hey, you got cancer in your body somewhere, man. So you got this little bit of protein, we need to look, right?
Thank you. And then lastly, in terms of, I'm not sure if I'm pronouncing it correctly, creatine that you mentioned, creatine. What is
No.
that? And then I'm hearing creatine proteins, like a powder. So
Yeah,
if there's
no.
a difference.
That's what I
Yes,
did.
thank
this
you for
one.
addressing.
When you say creatine, that's the stuff that you drink powder and get your muscle strong, okay? So creatine is a part of muscle, period. The breakdown product or partial breakdown product of creatine is creatinine. So if you get any bodybuilders in here? Okay, good. So if you get, I used to be one, so if you get a meathead bodybuilder, his creatinine is going to be higher than other people his age and his height because he has more muscle mass. So again, the nephrologist kind of knows that. And so that person may calculate at a stage 2 kidney disease. But because they have more muscle mass, their creatinine is higher, which means they're going to calculate a GFR lower. That might be normal for that guy, right? So that's where the creatine and creatinine comes in. That's where that comes in, all right? So I don't recommend drinking a bunch of protein shakes. You're going to bodybuild. If you want to bodybuild, you can.
No, but I've heard that it helps lose weight, and I'm trying to lose weight.
It does.
And that's why I'm asking.
It does from the standpoint of building muscle, okay? Building muscle improves metabolism for fat burn, okay? But it's got to be done in moderation. It's got to be done with some planning. You know, I put 2 people on dialysis for taking creatine too much when I was in New York. 2 young men were slamming creatine shakes 4 or 5 times a day for months.
Thank you, doctor.
Yeah. Wait, you had a question first. Sorry.
Alcohol.
Why are you saying alcohol? You know I went to Tulane in New Orleans. I don't do that anymore. I'm kidding. I'm
That's
kidding.
the past.
Yeah.
Is that, you said the #1 cause of kidney disease is diabetes, but how about alcoholism? Where does that fit in the
It fits
cause?
in. It fits in for sure. And other drug use as well. Drug use is associated with certain kidney lesions that lead to chronic kidney disease, particularly in African American and Latin communities. Alcohol is a double-edged sword. Alcohol does cause problems. Alcohol shuts off things for your body to retain water. And so you get dehydrated quickly. And that dehydration then tells the kidney, shut off function, basically, right? Alcohol also starts affecting liver cells. Kidney and liver cells talk, kidney and heart cells talk, kidney and pancreas cells talk, kidney and lung cells talk, kidney and gut cells talk. The kidney, bad boy. Kidney's a bad boy. So the alcohol, when it starts affecting the liver doesn't talk to the kidney as like it should. So therefore, the kidney's like, all right, well, you're not giving me any messages. I'm not going to work. Right? So not directly, unless it's over and above. If your alcohol level is like you sloppy drunk, that's affecting the kidney directly. But even little bits of alcohol actually stop that communication between the liver and kidney, and it shuts down that. So, you know, when you're having your little cocktail, make sure you have some water between cocktails, and you should only have 2. I'm just giving you advice. But alcohol is not, unless you are just going nuts, it doesn't directly impact kidney tissue, but it does have an impact. Okay. I saw over here.
How do you feel about genetic testing
Love it.
for families when, especially if you have the elders that had passed away or are dealing with kidney disease?
Love it. Love it. Great question. I gave a talk a couple years ago to the regional NMA conference explaining genetics in kidney disease. And 52% of African Americans have a gene called APOL1 that hastens kidney disease. So you know about malaria, right? And you know what sickle cell trait does. It protects African Americans from the malaria bug, okay? Similarly, this gene protected African Americans from something called African sleeping sickness or trypanosomiasis. So it's an adaptive gene, but we know that it hastens kidney disease. So right now what I'm doing in my office, I got a bunch of kits stacked up. If someone fits the bill, I'm swabbing them and checking that gene, because I don't believe in just checking genetics just to check genetics. There are a couple of drugs in the pipeline right now that will help stop the gene from being turned on to hasten that kidney disease when there's a lot of inflammation around. And that's what happens. And so the statistics are there in African Americans. Now, what's interesting, and let me just say it. What's interesting is that our Latin brothers and sisters actually are starting to turn up with this gene. Now, don't get me on my soapbox about migration patterns and all that and go back in history. But so I think that we're looking at that gene in African Americans, which is much more highly prevalent. We need to come up with a screening paradigm for all cultures. And that's me being a little bit political because of where civilization started. But it is, to me, if we can prevent kidney disease in anybody, we need to do that. And if this is a tool for us to do that, and then we also have drugs coming down the pipeline, we need to do that, right? So I'm a big advocate for that. There are certain other types of kidney stone disease that is genetic. There are other genetic kidney diseases that are out there. Unfortunately, some of those diseases we don't have a cure for, or we don't have a treatment for, I should say. So for me, I'm like, well, I'm not going to spend the money testing and I'm not going to do anything with it. That's just me as a physician. But some of the stone diseases, we got new drugs on the market to prevent certain types of kidney stones from being formed. And we got this APOL1 two drugs on the market, or not on the market, but in the pipeline for that. So I'm a big proponent of that. Yes, sir.
Hi, I'm Brent. We're in the skilled nursing business, and so 1 in every 4 patients that we treat at our facilities normally have the kidney disease. What can we do to be a part of the solution?
I was medical director of a skilled nursing facility for, I think it was 5 years, for that very reason. The fastest growing population of kidney disease patients is in the elderly. And the elderly in a skilled nursing facility have much more difficulty. And how do I mean? I mean because just the whole model. Now, I'm putting my public health hat on now. The whole model of go to the office is like ridiculous, because the payers are paying for transportation there. The patients are often sicker in the skilled nursing facility than someone out in other facilities, and more debilitated. It makes sense, just like just like y'all have the ophthalmologist coming by or the neurologist coming by, you need a nephrologist coming by. That's what I've been trying to do for years, is just say, hey, even my patients today, when I get a call from the skilled nursing facility, they want to make an appointment, I say, okay, I'll come to you. Don't worry about it. I'll be there. So I wind up going to the skilled nursing facility. As a matter of fact, I got to go visit a guy today, because I told them, don't bring him into the office. For you guys, staff time is gone. Sometimes you have to chip in with transportation based on what insurance they have. A lot of times no, but sometimes you do. So it's an added cost that benefits you nothing. And if I'm going to the facility, then I can actually see boots on the ground, what's happening with them, right? It's a different ball game, because sometimes the patient can't talk to me. So here's what I did at my facility for the dialysis patients who were in the facility. I created a wing of the facility, if you will, where there would be dialysis patients. That's anytime we admitted a dialysis patient, they would go over there. As medical director, I trained some of the RNs and LVNs on what to look for in the access. What does blood pressure mean in a kidney patient like that? When they come back from dialysis, what should you be looking for? I had a whole program on that. And I think that needs to be had in the nursing facilities, because we're not going to have any shortage of elderly people in the next 10 years, which means we're not going to have any shortage of kidney patients. We're not going to have any shortage of dialysis patients. People have told me, if somebody's 80 years old, why are you starting dialysis? Because I'm in the United States of America, and we don't cut people off like that, number one. If I got a strapping 80-year-old, oh yeah, they starting dialysis. Oh yeah, if they're out playing tennis and stuff, dialysis. Oh yeah, we're going to keep you around. You know what I mean? And the transplant centers, I actually took on an interim transplant job for this same reason, is to see, okay, how are we getting more people transplants? What are y'all really doing back here? You know, I wanted to peek behind the curtain. So we can transplant older people, which we weren't able to do before. There used to be just a cutoff, 70 years old, boom, you don't get any more transplant. Now there's not Cedars. Yeah, Cedars. Cedars does up to 72 years old, but you can kind of negotiate with Cedars too. If the patient looks great and their assessment looks good and your assessment looks good, man, we might have them go for it. I haven't had that yet, but I've had talks where they've actually been open to even looking. Whereas most places are like, no. What is it, Mayo Clinic in Arizona? They've done an 84-year-old transplant. So it's on and popping for the seniors, right? And that's what I like about you guys being at this, because you're right. more kidney patients are in the nursing home, percentage-wise, than are out in the community. And again, that's why I became a medical director, because I wanted to see all facets of how healthcare works for the kidney patient. And we did some great work at that time. We kept hospitalizations down because our nurses knew exactly what to look for, knew exactly what to do, knew when to call me, when not to call me. It was great. It was great. The recidivism that happens with a dialysis patient, for instance, going into the nursing home is like, it's an open door. I mean, they go back within 30 days, like 5 times before you figure it out. And then, okay, then they'll stay for about 6 months. But it's like they're going back and forth to the hospital. So I commend you for being here. I really do. That's awesome. All right. I know I'm over time now. All right, last question.
Someone can translate Spanish.
Okay, so her question is she able to get a transplant for her liver and kidneys? So 2 organs.
Together?
Yes.
Yes, we've done that before. We've done that before. All right. Usually we do pancreas kidney because diabetes is so common. We're doing a kidney transplant, do the pancreas transplant, you get cured. But we have had liver kidney done in this country. Yes. So it's a possibility.
Wow, that was great. Okay, so we'll continue on. Diana Breyshtrus, you are with us? Yes, so I'm going to say a brief word as you're coming on up here. She's MSN, RN, a ton of titles. She completed both her undergraduate and graduate degrees from Western Governors University. She began her nursing career on a medical surgical floor, specializing in postoperative nursing care in a multi-specialty unit, including urology, general surgery, trauma, surgical oncology, and obstetricians and gynecology. She later transitioned to Cedars-Sinai's Comprehensive Transplant Center. Since 2020, she's worked as a member of the transplant team and helps facilitate multiple aspects related to post-kidney transplantation care and coordination of long-term management of transplant organ recipients. So without further ado, Diana, it's all yours.
Perfect. Thank you so much. Again, thank you, Kidney Quest, for having us. Thank you, Dr. Anthony. What a great presentation. What so much insightful information. Thank you for everything that you're doing for the community and for nephrology patients. One thing I have to say, I'm from Cedars-Sinai transplant team. We actually not too long ago transplanted a patient who was 84 years old. We actually, a couple of years ago, we had a patient that was 89 years old that was transplanted. Granted, it's sort of an outlier, but nonetheless, we absolutely do welcome everybody. So without further ado, we're going to have a little talk about our kidney transplant and sort of understanding the steps of the transplantation. So there's been a lot of talk about kidneys, so I thought that we start off by having a little better understanding of what a human kidney is and what it does. So kidneys is one of our vital organs. It's shaped like a little kidney bean, and it's about about the size of our fist. Typically, we have one that's located on each side of our spine, or on the right and on the left. Some of the functions, I think the doctor had mentioned, but it's a very long list, but some of the main functions of a kidney is that it helps to filter blood, it helps to remove waste and extra fluid, it helps to maintain balance between acid and base, regulates our red blood cell production, it helps to regulate our blood pressures, and it also activates our vitamin D for those strong and healthy bones. Some of the common testing to find out what the health of your kidney is blood work the doctor had alluded to earlier. So to help evaluate the effectiveness of the waste, we refer to that as eGFR. We would also do some urinalysis, some urine tests to see what that looks like. Perhaps your doctor could order some imaging as well as a kidney biopsy in certain instances. Based on all those testing and evaluation from a doctor, here are some of the possible indications for kidney transplant. They might include, here are the most common causes of a chronic kidney disease. This list is much longer than this, but these are some of the common things. Diabetes or diabetics is one of the things that leads to a chronic kidney disease. Hypertension, that's our blood pressure. Polycystic kidney disease, some autoimmune disorders, as well as congenital disease. So if you have been diagnosed with any of those, that would be a good indicator and for you to be referred for potentially to be evaluated for a kidney transplant. So really you can be referred for a number of different reasons, and really it would be any condition that can potentially lead to an end-stage kidney disease. Stage 4 or 5 chronic kidney disease. And then if your eGFR is anywhere between 20 to 30 mLs per minute. You can also be referred preemptively. You may not necessarily be at the end stage or stage 4 or 5. We do evaluate patients for preemptive transplants. Obviously, there's certain things that are involved with that, but a lot of the time it's before the start of your dialysis. With preemptive, it also helps it extends your life. It provides a better quality of your life, and it also helps to combat and lower some of those treatment costs. So what are some of the benefits to a kidney transplant? You live a longer, healthier life, better quality of life, no more need for dialysis, you have higher energy levels, you can enjoy life more in terms of work and travel, makes it a little bit easier, and there's less restrictions on all those meals that we all enjoy. So here are some of the stages of transplant. So it all starts with a referral. You are then evaluated, you are then waitlisted, you are then kidney transplant, and then you are seen in the care for transplant in our after clinic. Okay. So we have a QR code. If anybody needs to, you can also refer to this email. So referral can be really done by anybody. It can be a self-referral. You can be referred by a physician. You can be referred by a by a dialysis unit. So really, there's a number of ways for you to be referred. And of course, just like everything, it has to be insurance authorized. So as long as your insurance authorizes you to be seen by our transplant team, then of course you will be seen and evaluated. If you are denied due to insurance, then you will be notified. One of our nurse coordinators will let you know who your contracted transplant center is. Throughout this referral process, we will request and we'll obtain some of your medical records, which may include your most recent MD notes, some of the most recent labs you've had, imaging or biopsies, or anything else that you have recently, any kind of workup that you've had. Once that initial clinical review is completed, you will then be invited to meet our transplant team. And also, this might be a little bit unique to the Cedars-Sinai team, is that we do accept patients with previous transplants. Okay. So what does that evaluation process look like? You will meet with our multidisciplinary transplant team, which consists of our nephrologists, our surgeons, nurse coordinators, social workers, finance coordinators, and dietitians. You will undergo complete lab testing. We'll do blood work, we'll do urine tests, we'll do some blood typing, we'll do some immunology testing as well. Once once one of the doctors will assess, they will determine or review all the records, they will determine if there's any additional testing that is needed. Perhaps you need an additional workup by your cardiologist or pulmonologist, or maybe some additional lab testing, maybe a genetic test. So once you're seen, the doctor will determine that. And then after that very first visit, we will provide you with a list of things that need to be completed within a 6 months period. Okay. Once that evaluation is complete, your case will be presented. Each case is presented and discussed among the members of a multidisciplinary transplant committee to determine if you would be a good candidate for a transplant. The purpose of this is for the team to evaluate if a patient is healthy enough and strong enough to undergo surgery, and also to help identify what their support system looks like. It really does take a village to help manage a patient after a kidney transplant. And I believe we have some kidney transplant recipients who can probably attest to that as well. Once that committee meets, once your case has been presented, a decision is then made. You can potentially be listed as an active member on the list, or can be inactive. And a lot of the time there's a number of different reasons that go into that. Once you are listed, whether active or inactive, a transplant coordinator will call you and they will let you know. You will also receive a letter that states that you have been listed. During that case presentation, sometimes it could be deferred because there are additional testings that perhaps our surgery team is requiring, or perhaps there's been some changes since we last saw you. So it could be also deferred based on some additional evaluation. And then the team can also deem you as not a candidate. That means that you do not meet the criteria that is required to be listed. If that happens, you will be notified by one of our nurses, and you will be given a reason as to why you're not a candidate. Okay. So now that you have been listed, sort of what's next? Next comes the wait list. Keeping yourself as healthy as possible, making sure that you stay in close contact with your nephrologist and you follow up with all of those appointments. You follow the outlined restrictions for your dietary and your fluid needs. You make sure that you attend and adhere to the dialysis schedule, and always be ready to travel if that call does come in. It's also important to keep in contact with the waitlist team. You will let them know if there's been any changes to your condition, if you have been hospitalized, if you have been started on any new medication, if you have been diagnosed with anything new. We also have patients that undergo different blood testings that are required for you to stay on that list. Okay. So make sure that you keep your transplant team up to date. It's obviously very important. Also, maybe you can help to identify if you potentially have a living donor. That's something we have a very elaborate team as well that helps to identify that, and there's going to be a presentation about that shortly. So if there's any changes to anything, please let us know. You have moved, you have, there's change of insurance, you have a change in caregiver. If there's anything, please stay in close contact. I believe our visits are annually, so we do see you quite often. You also, I mentioned earlier, there's some antibodies testing that is done. I don't know if anybody here is currently on a list, and then anybody has ever heard that you have sort of high antibody level. That's also unique to Cedars-Sinai, and there is additional testing that we can do. There's a lot of different things that we can do for potentially if it's not necessarily that compatibility is there. And some of that can be caused by blood transfusions, pregnancies, or even potentially previous transplants. So if anyone's ever told you that you have a lot of antibodies, please see our team when we can sort of help to decipher all of that. Okay. One thing that we didn't talk about is, the wait list, especially in California, there are, and I looked this up, on March 18, there are over 94,000 patients who are currently waiting on the transplant list. So that wait time is definitely pretty long. So always talk to your doctors, to your nephrologist, to see if you potentially could be a candidate for that listing to be earlier. Wait times are often based on where you are physically located, and then also depending on blood type. Type O and type B are some of the longest wait times. At Cedars, we do perform transplants that allows patients who have with one blood type B to accept a kidney from a different blood type as well. But based on blood type, you can also wait around 5 to 9 years for a transplant. So what happens once that organ offers come in? So organs, so UNOS is our United Network for Organ Sharing. They operate nationally. They help to facilitate organ recovery, organ placement, and they work closely under contract with the U.S. Department of Health and Human Services. The allocation for the kidney is usually started off locally, so it goes to your local area first, then it's offered regionally, then it's offered nationally. And it's also based on blood type, wait time, and sensitization. So organ offers from deceased donors come in two different types. You can have a donation after brain death. That's when a doctor has legally pronounced that you are brain dead. And if you, one of those individuals who have selected to be a donor, then that team comes in. You can also potentially receive an organ from a person who's what we call donation after cardiac death. So patient's heart would have to stop before any kind of organ procurement can begin. Some of the organ offers that also come in have a higher risk criterion. So all donors are screened for different infections such as HIV, hepatitis B, and hepatitis C. It actually within the last couple of years, as you know, sometimes we don't have the full story of or medical history of any particular donor. It is now a requirement that all donors, all recipients, all organ donors are screened for all of these various infections, hepatitis B, C, as well as HIV. Recipients will be notified if there is any risk criteria, and then of course that is something that you would have to consent to. However, we do have effective therapies should this be one of those scenarios. So for our hepatitis B donors or who have been exposed to hepatitis B, the risk of transmission is extremely low. We might either order a medication for you, or it's something that we might screen and monitor for. We also recently have started accepting donors who have been exposed or who have even an active infection with hepatitis C. If this particular donor does not have an infection, then it is something that we just monitor for, and if there is someone with an active infection, then we do offer treatment, and 98% of that time that treatment is effective. Okay. If you have blood type B, you might be able to receive a blood type A kidney that might require some additional monitoring, might require some additional medications and plasmapheresis. We might also accept kidneys that are high KDPI, which stands for Kidney Donor Profile Index. So this is basically any kidney that it sort of is struggling to find a good word for it, potentially is sort of a higher risk kidney, if you will. Sometimes it's offered for patients who have a very long wait time on the list. It's offered under those circumstances if you potentially do not want to stay on the wait list for a very long period of time. But that does, if you do sign up for KDPI kidney, it does not prevent you from having or being offered sort of a standard offer, if you will. And like I said, this is something that does require consent, but it could potentially shorten your wait time on the wait list. And it's something that you can definitely discuss with one of our transplant nephrologists. Okay. So always be ready for that call. When a deceased donor organ it becomes available, and it can happen any day and night, we do ask our patients to have your phone nearby. So if you do receive that call, that you connect with that nurse coordinator right away. You will be given instructions on when to go and where to go. Sometimes those calls could come in as a block, so make sure that always get answered and always get called, as if we are not able to reach you, we sort of, we'll assume that it's been declined, and unfortunately, we're just gonna go to somebody next on the list. Make sure that you have your belongings with you, maybe a little bag just of anything. Always have your med list ready to go also. Okay. Sometimes it could also be that it's potentially a false alarm, but we do ask you to still come in. And unfortunately, there have been times where we had to send you home, but you still stay on the list. You're still part of the family. Okay. All right. Care after transplant is pretty robust. You see us in our clinic very often. We do require caregivers, as it truly does take a village to get you over that threshold. And of course, we always ask that you stay in contact with your nephrologist, as that we cannot do this without them, without their assistance. Okay. Right. So it's important. I'm going to assume I'm running out of time. So all I'll say is that it's very important to stay medically compliant. It's very important to stay in close contact with your team throughout this entire process of transplant. Thank you, guys.
Diana, that was so informative. Keep up the great work at Cedars. Quite an education we just got there. Thank you so much. Okay, Laura Puzia. Okay. Laura, I'm going to just talk a little bit about you real quick before you come on up. BSN pre-transplant recipient coordinator at Cedars-Sinai, once again. Laura started her career in transplant while still in undergraduate nursing school at Drexel University in Philadelphia, working on their urology post-transplant floor. After completion of her BSN in 2019, she transitioned to ICU kidney, liver, pancreas transplant, still at Jefferson University Hospital in Philadelphia. The sunshine called Laura to Los Angeles, where she worked at UCLA as a living donor coordinator before transferring to Cedars-Sinai again in the pre-transplant recipient coordinator role that she is currently in. So at this point, we'd love to bring her back up, Miss Laura Puzia.
Welcome. If you or somebody that you love has kidney disease, you're in the right room. Today, I'm going to share information that could genuinely change their outcome because of the type of kidney transplant they receive and how they receive it. Makes an enormous difference on how long you'll live and how well you'll have that time living. Those three numbers at the bottom of the slide here tell the whole story. Unfortunately, in California, the wait time for a deceased donated kidney from someone who's died is 8 to 10 years. I think one of our, Dr. Anthony Reggie said, our life expectancy, if you have diabetes on dialysis, is 5 years. So that number alone can be pretty jarring for people. So take a minute just to take that in. During that entire time, you would be on dialysis. So during those 8 to 10 years or up to 5 years, if you have diabetes, a living donor could last 3 to 5 times longer than a deceased donor kidney. That's why we're highlighting it here. It's really important. And if you get transplanted before you ever need dialysis, Diana had talked about this as well as Dr. Anthony, called preemptive, your outcomes could improve by 25%. Okay. When your kidneys fail, you have 3 options. I want to be honest with you about all of them. The first is dialysis. You'll see that over here to the side. Dialysis is life-saving, and many of you or family members or people you care for may already be on it. I want to acknowledge that. It's not easy, but dialysis is not a cure. It replaces only about 10 to 15% of what a healthy kidney does, which really isn't as much as we would hope for. And the 5-year survival rate on dialysis is around 35%. It keeps you alive, but it's not the same as a kidney. The second option is a transplant from someone who's died. This is a deceased donor transplant. This restores kidney function is far better than dialysis. The problem is California. The problem is the wait time, 10 to 12 years or that 8 to 10 years. It's also dependent on your blood type like we were talking about. That means years of dialysis before you might even get that call that Diana was talking about saying that we have a kidney ready for you. It's also why we highlight compliance and keeping yourself so healthy, because during that time, that's what we're doing, we're waiting. The third option, that's the one that I'm going to highlight here today, is a living donor transplant. A transplant from someone who's alive and chooses to give. There are different types. It could be someone you know. It could be also altruistic. You'll be surprised. In my time as a living donor coordinator, there was a lot of altruistic donors, meaning people that just care and they want to give a kidney to somebody else. So even if you don't directly know someone that's willing to give you a kidney, please start exploring and talking to people about it, because you'll be surprised how many patients or people are really altruistic and just wanting to help somebody else. The best medical option is the living donor transplant. The kidney lasts longer. It starts working right away, and it can be planned before you ever start dialysis. So we're going to talk about how to make that happen. I want you guys to see these numbers. Most people don't see them until they're ready in crisis, and that's also what Dr. Anthony highlighted a lot earlier. There are more than 20,000 Californians waiting for a kidney right now. The average wait in our state is 8 to 10 years. 11 people in this country die every single day waiting for a kidney transplant. That never comes. And while you wait, dialysis is only doing that 10 to 15%, like we said. Every year on dialysis also increases the strain on your heart. Dr. Anthony talked a lot about the connection between the heart and the kidney. That's something that we focus on as well, because like I said, every year it increases that strain on your heart. And that's why waiting isn't just uncomfortable, it also has real medical consequences. Our goal is to minimize time that patients spend on dialysis, and the few who can, to avoid it altogether. The message I want you guys to take from this is not hopelessness. One of the recipients earlier talked about never losing your faith, and so that's also what this is highlighting too. It is a little bit about urgency as well, because time is ticking and we want you guys to start planning for this if this is possibly your future. It doesn't have to be passive about this. Getting on the deceased donor waitlist is important, and you should definitely do that, but you should also actively be pursuing living donor transplant at the same time. When I say pursuing, I mean talking to your friends, family, your community, church, other organizations about this, because the only way for people to know is if you tell them. Okay, this is a chart here. These are the real numbers from the National Transplant Registry, not just estimates. Among patients between 18 and 34 years old, 90% of living donor kidneys are still working at 5 years. For a deceased donor kidney at that same age, it's 82%. For patients 65 and older, the gap is even bigger, 80% versus 66%. That's a meaningful difference in years of life with a functioning kidney. On the right side here, here's why the gap exists. When a kidney comes from a living donor, it goes from their body to yours in minutes, right? The healthiest possible handoff. A deceased donor can sit for hours before surgery. Diana had talked a little bit about our allocation, right? Local, regional, national, depending on where that is, that kidney is sitting on ice. There are other methods that we have now to kind of keep that kidney pumping, but generally it's sitting on ice, it's downtime. Versus with the living donor, it's handoff from one to another. About 1 in 4 deceased donor kidneys need extra time to start working after surgery, sometimes requiring dialysis in the first few days. That's another thing that's sometimes not talked about, is with deceased donor transplant is we gotta give that kidney a kick sometimes. And sometimes that means staying on dialysis, and it's not exactly the solution that you hope for when you tell someone you're gonna get transplanted. Sometimes we can't predict how long you'll be on dialysis for until that kidney starts to wake up. Again, the healthiest thing that you can do is pursue a living donor kidney transplant, because that almost never happens where you would have to go on dialysis. If you can get a living donor transplant before you even start dialysis, again, that preemptive transplant, you will be very lucky, and your outcomes improve by about 25%. Again, that only happens with living donor because we can actually plan for it. We can schedule a surgery in advance. The bottom line, if you're pursuing a living donor transplant, it's always better to pursue it sooner rather than waiting. If you know that your kidneys are starting to deteriorate over time, emotionally that's a lot to take in, but we also need to start planning. Okay. One of the biggest misconceptions I hear from patients is that they have to find a blood type match in their immediate family. And if you can't, it's over. That's not true. Let me show you what's actually possible. Your donor can be a family member, a parent, sibling, adult child, aunt, uncle, cousin, family friend, but they can also be your spouse, friend, coworker, neighbor. I actually have seen a lot of coworker transplants, interestingly enough. We have patients whose donors come forward after they share their story at church or on Facebook or simply by telling a friend. You're allowed to share that you need a kidney. You're allowed to ask for help. And like I was saying earlier, you never know how many people actually want to do something meaningful in their lives and give back to somebody else. That third category, a stranger who chooses to give is real. That's what I was talking about. We call it altruistic donation. People do this, they're inspired by the story. They heard they want to give someone a gift of life. Sometimes it's people who themselves had someone impacted by kidney disease that they couldn't help soon enough, and they want to give back. The most important thing on this slide here is that box at the bottom. If a potential donor has the wrong blood type, or if your immune system might reject their kidney, we are talking about antibodies and such, all these little nuances. Don't give up. That's what the transplant team is here for. Our job is helping to figure out which transplant route could be beneficial for you depending on what resources that you have. You have a family member who's blood type incompatible. We're not going to say, sorry. We're going to say, let's work together. Let's figure something out. Also at Cedars, we have a lot of different modalities to help in these situations. We say, come to us first. There are different forms of living donation. So there is advanced donation, or kidney paired exchange has made it possible for people who are incompatible to still receive a transplant. The donor gives the kidney to someone they match. Sometimes you might see this on TV, is they give it to somebody else gives it to somebody else. On TV, they call it a domino. It's not that simple in real life, but it's a way to kind of get your mind around how that works. You receive someone who matches you, it's a swap. Some swaps happen simultaneously. This is called our kidney paired exchange. You'll see that abbreviated up here, KPE. And others are separated by time. This is called advanced donation with a voucher. And when I say a voucher, it really means basically you have a little slip that says, someone donated for me. I get to cash this in one day, okay? Sometimes that happens because let's just say you're still preemptive, you're early on of dialysis, and it's a better time in their life to donate then, given maybe them possibly wanting to be a caregiver after surgery for you, or people have their own lives. Maybe kids are going to school, things are happening, and right now is the right time for them. What they can do, they donate in advance, and you get a coupon. And it says, someone donated for me, so I get to cash this in when it's time, when my kidneys are deteriorating enough where we can do a preemptive transplant. Okay, so again, if you're ever unsure, ask us about these options. There are way more than I'm even going to explain here, but please talk to us. Additionally, many centers, including ours, are willing to evaluate donors who may be located differently from their recipient. I have had a couple of patients, I have family on the East Coast, they're here. What happens is their donors can possibly get worked up elsewhere. They get worked up remotely to see, okay, let's just say they're a match. That makes things easier. If they're not a match, that's okay, but we need to know and we plan. So if you have a donor who lives in a different state and are unable to travel with you for the evaluation, come all the way to LA, stay here with you, do that whole process. It may be possible for that donor to be evaluated and have surgery even closer to their home. So talk to us about those options, okay? So instead of them traveling, the kidney is the one being transported. I want to talk to you guys about the process actually looks like step by step, because there's a lot of patients feel overwhelmed and their family members or whoever might be interested and they don't know where to start. Step one is getting referred. You can self-refer yourself to a transplant program, your kidney doctor, your primary doctor, your social worker at dialysis can even refer you, and then we decide whether or not you're a candidate. If you have not been referred and you think that you should be, please ask for that referral. The worst case is we review it and it's not appropriate, and at least you know and you're not waiting. Step two, once you're evaluated, your team will talk to you about the deceased and living donor options. Pursue both. It's not either or, and it's also, I highlight this a lot to our patients, it's not, I'm going to pursue deceased and then I guess after that I'll pursue living donation. Both happen at the same time. They can be parallel. You're pursuing getting on the deceased donor list, but you're also talking to other people and saying, I'm in this process. What do you think? I want to step back from the statistics. There are a few on here, but just to talk about what daily life actually looks like when you're on dialysis. Okay. If you're on dialysis right now, you know this list. If you are a family member of someone on dialysis, you probably also very well know this list. 12 to 15 hours hooked up to a machine, sometimes more than that, to plan every meal around what you can and can't eat, to be exhausted in a way that's hard to explain and people who aren't on dialysis might not understand, to watch your travel plans, your work, everything has to be pre-planned. I want to acknowledge that for you guys because that's hard, and it's also hard on the family members because you're doing it right along with them. As Diana said earlier, it takes a village after transplant. It also takes a village keeping you well before transplant. Looking at this right column, it's what most patients experience after a successful living donor transplant. No machine, food that is closer to normal, energy that comes back often within weeks, not right away. Most patients return to full-time work within 4 to 8 weeks. Travel becomes possible again. Heart disease risk goes down. One of the most common things I hear from patients when we talk about living donation is, I could never ask someone to do that for me. I would feel too guilty. I'm going to pause here from my notes and just tell you a personal anecdote that someone once told me that was the wisest thing that I have passed along to my recipient patients. A social worker once told me and told a patient, when you tell someone in your family that they're not allowed to help you, you're taking away that option for them. And instead now they have to watch you suffer and know that you didn't allow them to help you. It's hard to ask people for help, but if people are offering it, consider it seriously, because it also impacts them long-term as well, the guilt that might come with them to not be able to help you when they wanted to and you didn't allow them to. Okay. With that being said, move on. Okay. I want to give you guys accurate information so you can make a real decision, not one based on fear. I know that sometimes in these slides kind of comes through because a lot of these statistics are jarring. Chance of dying from donor surgery is less than 0.03%. That's comparable to other routine abdominal surgeries like a gallbladder removal or an appendix removal. The lifetime risk of kidney failure is well screened. Healthy donor is less than 0.5%. Most donors spend 1 to 2 days in the hospital and are back to work, full normal activity within 4 to 6 weeks. We're almost at the end, and I want to leave you guys with something concrete, not just inspiration, not just saying go talk to your friends, your family, but actual next steps. So if you're a patient who needs a transplant, the most important thing you can do, talk to your doctor, talk to your transplant center about living donation. If you're already going through evaluation, it's something maybe you didn't think about beforehand, or you thought, I can't ask that of my family. This week, okay? Start telling people, post on social media if you're online. The impact of social media is unbelievable, okay? I know you guys can see that I'm on the younger end, okay? But I have also seen, truly, how many people post on Facebook and get so many donors that we can't even screen them quick enough, okay? It sounds like a pipe dream, but it's real. So talk to your family members, your next gatherings, go to church. You're allowed to ask for help. Donors come forward when they know someone needs one. They also wouldn't be offering if they didn't themselves think about this. So remember that. The people you're talking to are able to make their own decisions as well. If you have someone in your life who might want to donate, but you're worried about giving them the opportunity to find out if organ donation is safe for them, don't make assumptions, and also trust that we do not want to harm them. First and foremost, with anyone in healthcare, do not harm. A big thing also at our center and other centers is we always will highlight and focus on donor safety. This is voluntary for them. We're not under any intention to hurt them, and we want to make sure that if there's any risk for them, we're not going to put them in something that will disadvantage them in the long term. If you're someone in this room who's thinking about donating, maybe you came with a family member, or there's something that you're feeling in your heart is missing. Please know that reaching out carries no obligations. Your self-referral is confidential. Being also a recipient coordinator, working on the recipient side, we maintain a very strict privacy with our patients about their donors. There are a lot of policies in place to protect both the donor and the recipient. Also, for the donor, they can back out at any time, and the recipient does not need to know why. Your self-referral, like I said, is confidential. You can go through the entire evaluation and still say no at the end. No one will pressure you. It's entirely your choice. Then there's the financial side. The NALDAC, the number on the screen, can help cover travel, lodging, lost wages for qualifying donors. So it's something to explore. Pass that number along if you feel someone might be considering donation but might have some hesitancies about the financial aspect of it. That's it. So if anyone has any questions? Correct. So the question was, let's just say you're a female recipient. Can I have a male donor or vice versa? Correct. Also, I want to highlight that talking about the kidney paired exchange and kind of like that domino that I talked about, let's just say you're 60 and you have a possible 30-year-old donor. Sometimes the age discrepancy might not match. It might not be the greatest person for you. Then we encourage them to donate to someone else. That person has someone that's compatible with you. So like I said, even if it's not a perfect match in your eyes, that's what our transplant center is good at. We have so many different resources and modalities to make that possible living donor's kidney work for you. Oh yeah.
So the recipient does not have to have the same blood type as the donor. So that's another important thing. And then one other thing I wanted to mention with regards to transplant for the deceased donor list, the date you start chronic dialysis is the time essentially that starts ticking. So say you're here today and you're like, I really want to look into getting on a wait list. I want to pursue a kidney transplant. Rest assured that that time that you've already been on dialysis, or if you're not on dialysis but your GFR is at 20% or less, the transplant center will take that time and it will be considered. So that's all I want to say. Thank you.
Yep, thank you.
Laura, so great. Your knowledge is unbelievable. So we thank you so much once again for being here. Before we introduce our next guest speaker, as a special tribute to our members of the Kidneys Quest who have passed away this past year, they will be greatly missed. Just going to mention their names and we will, as a little tribute, Alejandra Zamudio de Bedolla, Gilbert Hernandez, David Alvarado, Rich Warren, and War Cardenas. Rest in peace. Greatly missed. Okay, moving on, we have another wonderful guest speaker. Mark, I'm going to talk about you just for a brief moment, then we'll bring you up. He is the Director of Public Education and Preparedness at the statewide California Earthquake Center. He's the Director of Public Education and Preparedness at the statewide California Earthquake Center, headquartered at the University of Southern California, where he works to increase earthquake and tsunami awareness and to reduce loss. He is also the Executive Director of the California-focused Earthquake County Alliance, which organizes the annual Great California Shakeout Earthquake Drill. He was recognized as a White House Champion of Change for expanding shakeout drills worldwide, which involve more than 50 million people each year. So without further ado, Mark, it's all yours.
I have normally could speak to you for a couple hours about earthquakes, and I know that's not why you all came here today. The important work that you all do in your organizations and with the Kidney Foundation, all so very important. And of course, when something like an earthquake happens, it just adds to all that you're normally having to take care of, right? And it's like the type of thing you need to be dealing with and thinking about: emergencies, fires, of course, too, and everything. And I'm going to throw at you a little bit that this is also Tsunami Preparedness Week. So if you're very near the coast or spend time, you need to know what to do if there was a tsunami alert, or if you felt a strong shaking. There might be a fault that happened just off the coast that might have moved the water up and down to what may bring a tsunami, so very little time. So we'll talk a little bit about that too. And, but of course, this is what we always need to be doing here, living in earthquake country. The Earthquake Country Alliance is really a group of many organizations, including with support from FEMA, the California Office of Emergency Services, and we work together. My home organization, the statewide California Earthquake Center based at USC, is an earthquake science research center that really looks at how we can better understand the earthquakes we might happen and we all may experience in the future. I mean, isn't that great that there are thousands of scientists working to better understand that? And, you know, that has led to, and while we're waiting for my presentation to be worked out, so the research we're doing has led to things like, and what we can take a moment here, do any of you have the MyShake app on your phone? Some of you do. I really encourage all of you to get out your phone. There it is. I just noticed it's down there. So, okay. If you could get that set up, then I can keep talking. So if you get out your phone, MyShake app is how you can get an alert that earthquake shaking on their way to you before they get to you. How does that sound? Like you get that heads up? So if an earthquake's large enough and kind of like not right where you're at, there will be enough time that the waves take time to get to you. They move very fast, thousands of miles an hour. But if they're, you know, it still could take time to get to you. You can get an alert on your phone. And it's not just a tone like you might get with the weather alert. Awesome. That says, you know, you have to look at your phone. You actually hear a recording that says earthquake, strong shaking expected, drop, cover, hold on, right? So if you get the MyShake app, go to your Apple Store or your Google Play app and look for MyShake. It's from the University of California, Berkeley. You install that on your phone and you'll get notifications. You might get notifications for larger ones too, just like you get a weather alert, but all you'll hear is that tone. The app, you'll actually hear that, so you won't even have to be holding your phone, because although we typically are always holding our phones these days, right? But I remember living in LA, my dad lived down in San Diego, this was in 2010. He felt an earthquake that was in Mexico, and he had to go find his phone, and by the time he got his phone and called me, because he knew the work that I do, of course, he thought I might be interested. By the time, it was about a minute, and I answered the phone, he said, "Mark, we just had a big earthquake," and then I could start to see my lamp start to, like ceiling lamp start to sway. Because in LA, that earthquake in Mexico was just kind of like that little rolling motion. So get the MyShake app on your phone. You'll get that alert, and it might save your life. And when you get that alert, don't do this. Oh, look at that's interesting. Hey, did you get this alert? Did you get this alert? Because it really could just be a couple seconds away. So immediately protect yourself. We'll talk a little bit about what you would do. And tell other people around you, hey, we're having earthquakes about to happen. All right. Okay. So I said a little bit of my organization, the research we do, the outreach and education we do. In the Earthquake Country Alliance, you all could join. It's free. Get on our email list so you'll get notification of webinars and events and things we do and all the resources that we provide. Okay, thank you. We have groups locally around the state and committees, healthcare and other nonprofit organizations. So ways that you can participate if you're interested in getting a little bit involved, or if you just want to get our info so you know a little bit to share. Our resources are organized according to the 7 steps to earthquake safety. Out on the table there, we do have some takeaways that you can get. All of this information's on our website, earthquakecountry.org. And the 7 steps are what you do before, during, and after earthquakes to be prepared to survive and recover. The more you do before a disaster in general, of course, hopefully the faster your recovery will be, the less injuries or damage in the case of earthquakes you might have. And if you're an organization that is in a situation like that, going to be called on to help others. Raise your hand if you're an organization that would be called on to help others in an emergency? No one? Okay. Do you know organizations that would be called on to help people? And I mean, do you any have clients? Or maybe I'm not understanding the type of organizations you're with. But after a disaster, whoever organization you're with, you're going to be dealing with that, and you can reduce the issues that you'll face. Okay, so step one is, you might think, oh, it's getting your supplies or such. We actually say the most important thing that you should do wherever you're at is to secure things so they won't fall. It sounds simple. It is simple work, and it's super important. There are far more injuries that people get from things that are falling or being thrown during earthquakes than from buildings collapsing. If you think about like the Northridge earthquake, raise your hand if you were here during the Northridge earthquake? Okay, good. Just checking also that your hands work, so good. All right, so a lot of people lived here in 1994. There were some buildings that did have collapse. That's where there were about 30 people who died because of building collapses, and just a few where that happened. Very sad, very type of poor construction. But there were tens of thousands of people who were injured because of broken glass or things falling or hitting them. And while there were a few buildings that collapsed, every room in every building in most of the valley and a lot of Los Angeles had a lot of stuff fall and or even be thrown. You probably can remember the mess you had to clean up. There is nothing too heavy to be thrown in an earthquake. We knew that there were fire engines thrown up into the air in their fire stations. If you think of how much ground is moving up and down and how small we are compared to that, right? So you can secure your space. We have a guide on our website, tells you how to do that. Really simple. It's something you can do over time. You secure your bookshelves, you secure your hanging objects, secure your kitchen cabinets, your water heaters. And we even have funding for organizations, for nonprofits. We'll give you, it's not funding, but we'll buy the stuff for you, send it to you, the fasteners. You can get up to $500 worth of these fasteners. And if you join us on our website, you'll get a notification when that opportunity comes out. It's an application. It's a simple application. You'll get the materials and you'll be that much safer. It kind of looks like this. There's straps that go into the back of the wall, and then it has Velcro that sticks to the item, and it really works to keep things from falling. Of course, your computer monitors and tabletop things like printers. In fact, the last time someone died in an earthquake in California was up in the Bay Area in 2014. A woman was asleep, elderly woman was asleep in her recliner. She had fallen asleep watching TV. The TV was thrown at her head. She had a head injury and died a few days later. If that TV had been secured, that would not have happened. Of course, our TVs have become really bigger and thinner. They're easy to knock over anyway. So these straps help. Even if you're just moving around and bump it, it will help that from falling over. Step two, now you want to think about what's your plan and all the things you can do to plan for what you're going to need, what you're going to want to do after an earthquake or really any disaster, and how you're going to communicate. If the phones are out, if your cell phones are out, if you're not able to reach, phones might work, but they probably won't work for local calls. The phone company will set up local calls just for emergency responders. You may be able to make a long distance call. So you may have heard about having an out-of-state contact. That's why you want to have everybody you don't want to coordinate know a certain number, family member or colleague that everybody can report in and kind of network that way. You want to make sure your planning is personal so that you think of the particular needs that you have, maybe for medications, it's not just a matter of having the same plan as everybody else. And one key thing in your planning is to make sure that you have fire extinguishers, maybe multiple ones at work, at home, in your car, that you know how to use them. It's easy to learn how. You can even just watch YouTube trainings right now. And because fires happen because of earthquakes, and if you can't put out that small fire, it's going to perhaps catch your home on fire. And there's going to be so much happening that it's likely the fire department won't be able to come to extinguish your house. And then what happens? Your neighbor's houses catch on fire, and so on and so on. So not only should you have a fire extinguisher, you should make sure that your neighbors have fire extinguishers, because if their house catches on, they have a small fire, you want them putting it out before it burns your house down too. Step 3, now you want to organize the supplies you're going to need. You have a lot of stuff already that if you are able to stay in your home, and most of us will be able to stay in our homes. We may not have power and water and gas at all, but we could stay there. So you may have enough food and stuff, but definitely no matter how much water you have already stored in some way, get more. Water may be out because the water mains of Southern California are decades, in some places over 100 years old, and the earthquake shaking is going to break so many of them that it may take a year or more to get that fixed. So you may have no water at your home for a very long time. So having more water, like on your way home today, go get more water. And you can buy it in small bottles, larger better. You don't want to have that like sitting around for over a year, so drink it and kind of recycle it. You can get a large water barrel, it costs about $80 to $100, but it holds 55 gallons. It's a special type of barrel, and it will last for 5 years. So I have 2 of those. So there's lots of ways. Get more water. Make sure that you have in your kit, your go bag, your different types, and we have this worksheet we have out on our table. You can have supplies in different locations, and you want to make sure that if particular things that you must have, if, for example, you were to go out on a camping trip in the wilderness where you can't go to a store or you can't go to the pharmacy, what would you absolutely need for at least 3 days? And make sure that you have that in your kit, like prescriptions, hygiene items, various things like that. And then get that organized and have it in those supplies in different locations. Step 4, you want to start thinking about, okay, I've got that going. What about what my life is going to be like afterwards? And what about beginning my recovery? I might need to contact my insurance. And if it's an earthquake, your regular homeowner's insurance is not going to cover your losses to your building or your belongings. You have to buy an additional earthquake policy. And even if you're a renter, you can get those. It's actually very reasonable to get renter's insurance. It's just covering your belongings if you've lost something. But one thing you can do is organize your important documents. On our website, we have lists like this list that you can kind of check off, and you want to have in your go bag or maybe online somewhere that you want to organize these in documents. Have copies of them so that you have your ID so you can show who you are. You want to have your pet identification too. You want to have all your financial information so that you can access your resources. If you can't get to where you normally have this information, you want to have your medical information, and again, your contact information. Super important. If you want to be able to reach someone, how many of us these days know each other's phone numbers? Like you could dial it without, you may know a couple of people's phone numbers, but back in the day, we always remember, we would know more numbers. Now it's on your phone. If your phone battery dies, you probably can't reach a lot of people that you would want to, especially if no other access to information. So in my wallet, I took and I printed out in a very small font, but I about 50 people's phone numbers and just put it on a little piece of paper and put it in there. That's, so that you have that. Do something like that. Okay. Now, step 5, now we're during the danger period. So what to do when you start to feel earthquake shaking, or now that you have the MyShake app, you've downloaded that, you'll get that perhaps 5 seconds, maybe up to 30 seconds notice that strong shaking's on the way. And you're going to protect yourself from the falling objects. Again, that's the most important thing, right? There's very low likelihood of building collapse here with all our very world-class building codes and a lot of the work that's been done even on retrofitting a lot of buildings. You don't want to run outside during earthquakes. Things fall off of buildings roof tiles, other things. And the previous deaths in California was in 2003 up in the San Luis Obispo area. There was an earthquake. There was a jewelry store where the owner told his employees, run outside. And there was a brick kind of facade at the front of the store, which peeled off and crushed them. And the thing is, that owner had been told of the hazard, that it was dangerous. So there was a lawsuit, of course, because he knew that that was dangerous. If they had stayed inside with the owner, they would have been totally fine. Building didn't collapse, just things fell off. So don't run outside and don't get in doorways. We should have never, no one should have ever told anybody to get in doorways during an earthquake. They're like this wide and things are falling. It doesn't provide any protection. It's not some magical safe place where if the building fell, the door would still stand and you would be okay. It's not a force field around the door or something. So don't get in doorways. And if this room was full, there aren't even enough doors to do that. And you can't stand up during strong shaking. Most of us have not felt the type of strong shaking that's possible. If you lived up in the San Fernando Valley in 1994, that's probably some of the strongest shaking that we will experience. But that only really shook for 15 to 20 seconds. It may have felt longer, and maybe the building kept shaking its own a little bit longer. But we can have shaking for up to 2 minutes in a San Andreas earthquake. And things that don't break and fall in 15 seconds, you keep shaking them for 2 minutes, it's going to be a different situation. So what do is we drop, cover, and hold on. You got these great tables here. You get down, if you're able to, get under the table so that the ceiling tiles up here and such, you'd rather them hit the table than hit you. If you're not able to get down, or if you're someone who uses a wheelchair, that's the lock part here. Lock, cover, hold on, lock your wheels so you don't roll around. Cover your head as best as possible. Or if for whatever reason you're not able to get down and back up again, just sit where you are, cover your head. It's all adapting to what you can do. And this could be any of us at any time where maybe you sprain your ankle, you hurt your leg or something that you're not able to do that. So it's important to know that option. And if you are someone who's going to do that, make sure people around you know, like that you know closely. Tell them, by the way, if there's ever an earthquake, don't drag me under the table, please. That could hurt you more. So we have a lot of guidance for what to do also out on the table there. And, it kind of looks like this. If there's a table nearby, you're going to get down where you're at. If you're not right next to a table, you might end up staying where you are. But if you can crawl under something for additional shelter, do that. And then also this person who uses a wheelchair, locking the wheel, covering their head. And we have other guidance for that too. This is, I was talking about earthquake early warning. You might get for a magnitude 5 or greater earthquake, a tone and a message. One of those tones, that you get, and all of a sudden, we all jump. But you'll have to go look. But for a 4.5 or greater earthquake, the MyShake app will start telling you earthquake, strong shaking expected, drop, cover, hold on. How many of you have participated in the shakeout earthquake drill? Excellent, excellent, awesome to see. Everyone is encouraged to do so. I've led shakeout nationally since 2008. This year it's happening, it's always the third Thursday of October. It's October 15th. And a lot of guidance for what to do. And it's a chance to practice without needing the real thing, what to do during earthquakes. Step 6, it's still during, because of course we can have the first couple of days, lots of aftershocks where you have to be ready to drop, cover, hold on. You might need to evacuate. There may be injured people that you're going to help, and you're going to do things to start preventing further injuries and damage. So evacuation is kind of a tricky thing because you don't necessarily know, is my building so damaged that I need to get out? But I mean, if walls are bent and you can see through walls, that's a good sign that, yeah, you're going to need to not stay there. After the shaking stops, then with caution, go outside. Obviously, if a fire is that you're unable to put out, you're going to leave. And you're going to go to your meeting place with those that you're coordinating with have talked about. If you're near the coast, again, this is Tsunami Preparedness Week this week. and you feel earthquake shaking, it could be that that earthquake was along one of the faults that are right offshore of us here. Good news is they're not likely to have more than a magnitude 7 or so. And for a large tsunami, you really need something like an 8 or a 9. Which a 9 is 1,000 times the size of a magnitude 7. And that's what we see on these big earthquakes that then cause tsunamis that come all the way from Japan or Alaska, Chile. Those are all that large. But right off the coast, we could have something that maybe would cause a little bit of coastal flooding. But most of our tsunami areas, fortunately, in LA County and Orange County, are really right at the coast. Like low-lying areas like Marina del Rey, Huntington Beach, it can go in a little bit further. And it's not like it always will, but the maps. So you can go to tsunamizone.org. You can learn about ways you can educate people, because how many of you live right at the coast or work right at the coast? Nobody? How many of you ever go to the beach or by the beach? Oh, yeah, good. So imagine you go there one day and you feel a strong shaking. You're going to protect yourself during the shaking, but then you want to go inland a little bit, and you're just going to walk, because most places you'll be able to walk to a safer location. You might get an official warning that an earthquake's happened across the ocean, and in that case, there'll be a few hours of notice, and they'll be evacuating people out. Okay, so that's this week, and you can learn more, and we have some postcards about tsunami safety over there too. And then finally, step 7 is what you do in that kind of longer period of recovery and kind of restoring connections and repairing damage, all those things. And I should say also, of course, I guess I've left a slide out here. You're going to perhaps help people who have been injured, right? And you need to know how to do that. So there's trainings. If you don't know how, you can take CERT trainings, Red Cross trainings, so you can do that. You're going to put out fires, turn off your gas if you smell a leak, all those things too. Okay, so step 7 is that longer term, and we have guidance there too on the website. All right, so how you connect with us. Oh, by the way, all these materials I've shown and messaging, we have in 18 languages on our website. So the top languages spoken in California. So definitely, we have some materials in Spanish here today, but lots more on the website. And you can reach out to us through the website. Also, we have a website in Spanish, chattermotos.org, and the email info@earthquakecountry.org. Now, looks like, I think I have a couple of minutes. If you have questions, yes. Yeah. Like a written prescription, even better, right? Yeah. Yeah. Like if you have to go to a shelter, they may not have that particular
right, so that you
dietary
know
need.
what you have to eat, that you have to take, because it's been extensive damage. Like during the Northridge earthquake,
Yeah.
there was extensive damage. So I would imagine that kidney patients that were in those areas couldn't get to the store, couldn't get to wherever. And so there's certain things you need to have on hand at all times for your own particular diet that are disaster related. But again, if an earthquake happens and my husband is on his machine, we've got to cut that line. We have to know immediately what to do. So be aware of when that happens, because we have extra needs in addition to what he's done a wonderful job at explaining. I just wanted to mention that.
Thank you very much. And might also think, yes. I'm not exactly sure what the equipment looks like. you might be able to some way even secure that so it doesn't move around immediately.
I wish we could, but it's on wheels.
There
It's
are
on
like,
wheels.
you can get
Yeah,
kind of
I
almost like
wonder
a
if we could.
bungee cord that,
Yeah,
it's
maybe we
something
could.
that you can,
Yeah.
you know, prevent it from
Rolling around.
instantly,
Yeah,
maybe if it
that's a
moves
good
quick,
idea.
it's good, yeah. So
'Cause
think through all
it's
of
on
these
wheels.
things. It's the key point, right? All of the situations. Yes. Oh, just giving the, any other questions? Even about earthquakes? Anything? So, all right. Well, thank you very much for your attention and all the work that you do.
I was going to say, I have one more that you should do.
Okay.
When you go to bed at night, you should have your shoes right at the bottom of your bed so you can put them on, because glass and whatnot can be down there and you need to put your shoes on, not go look for your shoes.
Let me agree with you but with an addition. So one of the things that we have on this bed, you see this aspect of the under bed bag. So, and we do have this checklist out there. We recommend that you put your shoes in a bag for exactly the reason you said. Glass can be all over the place. They can get in your shoes. Also, your bed could be moving around, so wherever you put your shoes, you may not be able to find in the dark. How many of you need glasses to see? And put your glasses on a night table. Well, those glasses are going to be gone. So put an older prescription in that bag too. Socks, a flashlight, and then take that bag and tie it to your bed frame. You can put it underneath your bed. That's why we call it the under bed bag. So the first thing you do is you reach down and you get that bag, and then you pull out your glass-free shoes. This isn't Cinderella, right? It's not the glass slipper. It's the glass-free shoes. I've never said that before. I should. And you'll be able to put them on and not worry about it. There was a story of a firefighter who, I think in the Northridge earthquake, got up, pull his boots on, you know, and get ready to go out, step down, and all that glass is ground into the soles of his feet. And you can't move at that point. He was not able to go and do what he needed to do. If you're racing to your kids in the middle of the night, if you have young kids, you go through broken glass. They're going to be coming and helping you. So minimize the potential for glass that could fall in the first place if you can. But yeah, great point. Have those shoes in a bag so that they'll be ready to go and you'll know where they're at and can find them, as well as your glasses and your flashlight and other things that you have. It's not a go bag, it's a get up and go bag. Okay? Great. Okay, thank you.
Thank you, Mark. Boy, he knows everything about earthquakes. Holy cow. Tsunami week. It's the week, Tsunami week, so get on the site and check it out. So what we're going to do, we're going to go to lunch for a half hour, and then we'll go to the individual rooms. You guys should have all the charts on that, okay? And then, so have a good lunch, and then at 1:30, Art is the one kicking off in his room, and have a great lunch. Okay.